Hello, I am going to be talking about the disablement model and injury prevention. I am a student at Indiana State University's Doctor in Athletic Training program, and my name is Chrissy Reichert. So today we're going to be talking about the disablement model and how it relates with injury prevention and health-related quality of life. Now, to help in aiding understanding, I'm going to be using the acute groin strain as an example throughout this presentation. So first we're going to talk about the disablement model and what it is. We're going to go and discuss a little bit of injury risk factors and then move on to injury prevention. And we're going to relate it all back to health-related quality of life and how these three all work together in order to maximize patient care. So first we have the disablement model. So what is the disablement model? A disablement model is essentially a very powerful organizing tool. It emphasizes the entire person by taking in 5 different domains. Now this picture does give 4, but I'll be going through it so there's no confusion. It basically is going to provide that framework for healthcare interventions and helps to address the patient's health-related quality of life, because as we all know, there's so much more to an injury than just the physical. Now, there are 5 domains in the disablement model. The first begins with origin. So what is the pathology or the condition? It begins at the cellular level or the tissue level. Next is organ. So what body structure is not working the way it needs to, and what is the impairment? Third is going to be the person. So we're looking at the functional limitations that this injury has caused. Finally, we're going to go into what says here is disability, but it's also known as societal and environmental. So how does this person's limitations change the way they meet their role in sports? Or how does it affect their social personality? And environmental is, what happened socially or personally as a result of this injury. So for an example, we're going to begin with the acute pathology. So here it's easy. It's a groin strain. Next, we're moving into impairment. So because of a groin strain, you have decreased strength. Moving on to functional limitations. So it's your inability or your decreased ability to cut, sprint, kick, punt, or jump, depending on your sport and your position. And finally, how does inability, otherwise known as societal or environmental factors, it's going to be the inability to fulfill role as a starter, an athlete, or in a sport-dependent position. Great, so now we've talked a bit about the disablement model, and we're moving on to injury risk factors. Now, there is a bunch of different categories that can all be used interchangeably. The first is going to be your intrinsic factors. So that's things that are happening within the body. Finally, secondly, your extrinsic factors, so things that are affecting the injury outside of the body. Modifiable, so these are things that are amenable to intervention. So that means that intervention can help to eliminate or prevent an injury from occurring. And now there's several factors that can go along with this. There's environmental, anatomical, neuromuscular, and hormonal. So in this instance, environmental would be something like playing surface, footwear, knee braces, coaching, reffing. Anatomical could be how much pronation you do when you walk. Neuromuscular could be strength or stiffness. And then hormonal, things that are not easily treated. And last is non-modifiable. So it's important at-risk individuals. So there are environmental, anatomical, hormonal, and demographic. So in this, environmental is like the playing situation or the way your opponent's behaving. Anatomical would be things like your Q angle, your postural alignment. Hormonal would be menstrual cycle or other hormonal concentrations that may not easily be treated. And demographic would be age, sex, height, race, things that you can't control. Now, it's a key note here that some modifiable factors are not feasible to change, whereas some non-modifiable can be altered with surgery. So in a modifiable factors, meaning playing surface. So even though you technically can control the playing surface, how feasible is it to do so? If you're a tennis player, it's not that easy to say I'm going to play on a clay court rather than a hard court. And then non-modifiable that can be altered with surgeries is something like your carrying angle of your elbows or the groove in your kneecap. Excuse me, the groove for your kneecap. All things that can help limit the chances of injury. Now, injury prevention. With this, we're going to be focusing primarily on the MuWise model. Now, the MuWise model takes into four or five, depending on how you look at it, factors that all contribute to injury. First, there must be an internal risk factor. So like we talked a little bit before, age, gender, body composition, anatomy, limb dominance, things that put the individual at risk they can't control. They have to have the internal risk factor. And just because they have an internal risk factor does not necessarily mean that the injury they have is because of it. You have to have an external risk factor. So level of competition, skill level, shoe type, ankle bracing or taping. These are things that you can control. But of course, you have to have a susceptible athlete. So even though an ACL is more susceptible on, say, turf, that's not necessarily going to be, a tennis player won't necessarily be a susceptible athlete. And finally, there has to be an inciting event. So a lot of people tend to miss this because they forget that there's a movement or a practice or a game that causes the injury. And then finally, the injury occurs. Now let's look at an acute groin strain, for example. You have an intrinsic risk factor. So hip adductor to abductor ratio. If the adductors are less than 80% of abductor strength, then you are more predisposed, as well as decreased range of motion of hip abduction. Now some extrinsic factors could be level of competition or sport. A swimming athlete may not have a higher chance of injury to the groin as, say, a soccer player. And finally, an injury can occur. But to do this, to understand how to prevent this final stage of injury, you have to take into all the factors. You have to take in the susceptible athlete. You have to take in the external factors. You have to take in the inciting event. All of these factors have to take place. You can't just look at the intrinsic or extrinsic factor and just assume that they're going to be injured regardless of what you do. So a keynote here is actually there is not a current golden standard for preventing an acute groin strain. So wrapping it all up, how does all this relate to health-related quality of life? First of all, let's define health-related quality of life. It's defined as the physical, psychological, or social domains of health, seen as distinct areas that are influenced by a person's experience, beliefs, expectations, and perceptions. So note in this definition that it's not just the physical. It is the beliefs, it's the expectations, it's psychological, and it also is social. If you take a look at the disablement model again, you can see that the disablement model takes into consideration all of those as well. It looks at the society, it looks at the environment, it looks at the factors that include it, not just the physical. When we take a look at history of athletic training research, we see that it is primarily all disease-driven, or disease-oriented research. You're trying to figure out why something happens, but you're not looking at the patient, how it affects them. Our profession is moving towards, well, this is a Doctor of Athletic Training program. We're trying to enhance and to promote higher education for athletic trainers. And if you look at professional, post-professional degrees, such as physical therapy, doctors, or chiropractors, they all take into consideration patient-related outcome measures. And like we said in the beginning, patient-related outcome measures are formed through the foundation of a disablement model, taking into consideration all the aspects of an injury. And like we said earlier as well, there's more to an injury beyond the physical. If we look at just the physical, we have no idea half of the injury. We're doing less than 25% of the work. And finally, we want to optimize our patient-centered care. We're here for our patients. So if we don't figure out why we're doing something for them, then we're not really helping them, are we? Thank you so much for listening. I hope this made sense to everyone. Here are the references if you would like to delve further into this topic, and I appreciate your time.